Have you ever just stopped and wondered, how do we actually separate real, rigorous scientific fact from dangerous fiction when making healthcare decisions? I mean, in a world absolutely flooded with flashy medical headlines, so-called miracle cures, and completely contradictory health advice, figuring out what actually works can feel, honestly, totally overwhelming. But what if there was a systematic way to just filter out all that noise? Well, welcome to this explainer. Today, we're doing something really exciting. We are diving in and demystifying evidence-based medicine, or EBM. We're going to give you the specific mental frameworks and the practical tools you need to critically appraise medical literature. By the end of this, you won't just be passively reading medical claims. You are going to be interrogating them. Okay, let's dive into this. Here is our roadmap. 1. Why we need evidence. 2. The dangers of bias. 3. Tools for critical appraisal. 4. Appraising a real trial. And 5. Making evidence-based decisions. Section 1. Why we need evidence. Moving beyond anecdote. For centuries, the main way medical knowledge was passed down was, deeply human, but it was also fundamentally flawed. It relied heavily on anecdotal experience. Now, it is incredibly tempting to base a huge decision on just one highly vivid story. Professor Tricia Greenhalgh, who's a leading expert in evidence-based healthcare, she shares a really powerful example of this. During her pregnancy, she was given an anti-sickness drug called Stematil. Within minutes, she experienced this uncontrollable, deeply distressing neurological spasm. And because of that one terrifying personal anecdote, she never prescribed the drug again, even though the statistical reality is that a reaction like that only happens in about 1 in several thousand cases. This is the trap, right? This is the danger of decision-making by anecdote. It ignores the collective experience of millions in favor of one isolated event. Instead, modern medicine has to rely on objective mathematical estimates, things like the number needed to treat, or NNT, to objectively weigh the good against the potential harm. And this perfectly illustrates the core definition of evidence-based medicine from Greenhalgh's book, How to Read a Paper. Listen, evidence-based medicine isn't about ignoring the patient's story. Not at all. It's about using high-quality research from massive population samples to get real mathematical estimates of risk, benefit, and harm. And then you take those hard numbers and use them to guide the clinical care of the actual individual patient sitting right in front of you. But we also have to be super careful about where our rules come from in the first place. Historically, clinical guidelines were often put together using a method jokingly called GOBSAT. Literally, good old boys sat around a table. You take a dozen eminent experts, shut them in a hotel room, and just let them argue until they reach a consensus. The problem there? Putting a bunch of experts in a room can sometimes just multiply their own individual, unscientific biases. True evidence-based medicine demands objective, systematic reviews, not just the loudest opinions in the room. Which brings us to Section 2, the dangers of bias, when bad evidence literally costs lives. Because what actually happens when critical appraisal fails and flawed, biased research makes its way into the world? It isn't just some academic problem. It has devastating, real-world public health consequences. Just consider the tragic timeline of the infamous and now completely retracted study that suggested a link between the MMR vaccine and autism. According to researchers Smith and Noble, this study was just riddled with bias at pretty much every level. The selection of participants was heavily misrepresented. The sample size was way too small to draw any kind of firm scientific conclusion. Yet, the results were massively overstated when published, suggesting we urgently needed to rethink vaccination. And the result of that? A total media frenzy that fueled a massive drop in vaccine uptake. Within a 10-year period, Britain saw a 25-fold increase in measles cases. That is huge. This is exactly why understanding bias is so absolutely crucial. Bad evidence can and does cost lives. Section 3. Tools for critical appraisal. Filtering the gold from the junk. Because we need specialized mental metal detectors to filter out the methodologically flawed junk and unearth the rigorous scientific gold. The very first line of defense is just making sure the researchers actually reported their work properly. This is where standardized statements like Consort and Prisma come into play. Consort dictates exactly what specific information we should expect to see in a published randomized controlled trial, while Prisma does the exact same thing for systematic reviews. If a published paper doesn't meet these basic reporting standards, boom, it is immediately a red flag. Now, what's really interesting is what happens once a paper passes those basic reporting standards. We use a tool to appraise the actual content itself, the CASP checklist. CASP stands for the Critical Appraisal Skills Program.
This specific checklist gives us 11 systematic questions to help us make total sense of a randomized controlled trial. And the best part? You do not need a PhD in statistics to use it. You really just need to know what to look for.
The CASP appraisal process breaks down into 4 really logical phases. Step 1 is basically the screening phase. Did the study address a clearly focused question and actually randomize its participants? If the answer is yes, we move to step 2. Was the study methodologically sound, like were the patients and doctors blind to the treatments being given? Step 3 asks, what are the actual results and are they precise? And finally, step 4 brings it all back to reality. Will these results actually help the local population that you care for? Section 4, Appraising a Real Trial, the 2001 Davies et al. DSN study. Let's take that CASP framework for a test drive, shall we? We're going to appraise a real, prospective, randomized controlled trial by Davies and colleagues that evaluated the effectiveness of diabetes specialist nurses, or DSNs, in a hospital setting. First, let's look at their study design. The target population was patients with diabetes admitted to a single hospital. With informed consent, they were randomized into 2 arms. The intervention group got usual care plus structured education and advice from a diabetes specialist nurse. The control group received usual care only. The absolutely crucial takeaway here is that a control group is essential. By comparing the new intervention against a standard baseline, the researchers can actually check if any improvements happened purely by chance or if they were genuinely because of the nurse. Now, before the study even kicked off, the researchers ran a power calculation. They figured out they needed exactly 140 patients in each group. Why 140? Well, the statistical math told them this specific number would guarantee an 80% chance of detecting true differences between the groups if they actually existed. If you use too few patients, you might miss a major breakthrough, but use too many and you're just wasting resources. Okay, now for phase 3 of our CASP checklist, the results. The primary outcome the researchers measured was the length of stay in the hospital. And the data showed that the intervention group, the folks who saw the specialist nurse, had a median hospital stay of 8 days. The control group, however, stayed for 11 days. Think about that. That is a full 3-day reduction in hospital time just by adding a specialist nurse. But hold on, how do we know that 3-day difference wasn't just a lucky fluke? Well, we look at the p-value. The researchers reported a p-value of less than 0.01. So, in plain statistical terms, this means there's less than a 1 in 100 chance that this difference happened by accident. It is highly statistically significant. Those specialist nurses genuinely caused the patients to recover and go home sooner. And the good news didn't stop there. When looking at secondary endpoints, patient satisfaction was significantly higher in the intervention group, with a staggering p-value of less than 0.001. Their knowledge regarding their own condition vastly improved compared to the control group. Plus, there were 0 adverse effects. Sending them home 3 days early didn't result in faster readmissions. The intervention was an absolute, overwhelming success. Section 5, Making Evidence-Based Decisions. Applying Findings to Practice. Look, having a statistically significant result on a piece of paper is wonderful, but the ultimate goal is applying those findings to actual real-world practice. This is where the rubber meets the road. The final section of the CASP checklist, Section D, becomes the most important part of your appraisal. Will the results help locally? You really have to ask yourself, are the study participants actually similar enough to the people in your specific care? Do you have the resources, the time, the finances to introduce this intervention? For example, the Davies study proved diabetes specialist nurses are highly effective, for sure. But could your local clinic actually afford to hire one? Can you disinvest resources from an outdated practice to reinvest in this proven one? Because at the end of the day, evidence without implementation is, honestly, just trivia. We've covered a ton of ground today, from the real dangers of relying purely on anecdotes and biased research to the incredible power of structured appraisal tools like Consort, Prisma, and CASP. We've seen firsthand how a well-designed trial can definitively prove the value of a healthcare intervention. So I want to leave you with this final thought. The very next time you see a flashy medical headline or hear about some revolutionary new treatment, what are you going to do? Will you just take it at face value? Or will you use these tools to dig a little deeper, ask the hard questions, and find the real truth hiding in the data?